Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. I have with me Dr. Dawn Abbott. Dr. Abbott is Associate Professor of Medicine at the Warren Alpert School of Medicine of Brown University. She is also the Interventional Cardiology Program Director at Rhode Island Hospital of Brown Medical School, both in Providence and Rhode Island. Dr. Abbott, welcome to the show.
Hello. Welcome. Happy to be here.
Sure. Thanks for making the time. And I want to congratulate both you and Rian Davies for putting together an excellent paper for US Cardiology Review. The paper is titled Percutaneous Coronary Intervention, Developments in the Last 12 Months. And there have been a lot of developments in the field over the past 12 months. And we're going to talk about a lot of those studies and trials and, pick your brains and also your expert opinion on what you think about these studies. So we'll just dive in right away. The first study which you've written about in the paper is a study which was heavily debated and also received a lot of lay press, particularly the New York Times article, which made the headlines and caused a lot of controversy. I'm referring to Rasha Alami's Orbita trial. So why don't you tell the listeners a little bit about that study?
Sure. Orbita was certainly a landmark trial in that it was the first sham-controlled PCI trial that's been done, which is to great credit of the investigators. The patients were blinded to, they had access performed and were blinded to whether a PCI or sham procedure was done. About 200 patients were involved in the study, and all the angiograms were published, which showed, the majority had clearly angiographically significant lesions. At the completion of the study at 6 weeks, the study did not show a benefit to PCI, which was, I think, a surprise to the investigators. But they acknowledged the limitations that these patients were quite stable at the time of enrollment because they had been optimized on medical therapy, had very low levels of inducible ischemia by multiple pre-procedural stress methods, including stress echocardiography. And also the duration of follow-up was quite short. It was only 6 weeks. So we really can't speak to whether these patients would have remained stable over a longer period of time. One thing I think is quite interesting about the sham-controlled trial is that while there can be a perceived benefit to getting a procedure you don't get, there can also be a perceived harm. And one of the concerns that was brought up is that if patients are unaware if they received the stent or not, they may be uncomfortable performing the assessments like stress testing during the follow-up period because they don't want to push themselves. It's like a reverse bias in my mind. So those were all very interesting aspects of the trial. I think the take-home messages are we need to talk to our patients more about their symptoms. We need to understand whether their symptoms are due to epicardial coronary disease or other forms of angina. And I think this does allow us to be a little more conservative when we have patients that are very similar to those enrolled in the trial. I think we have to caution against extrapolating these results to patients with unstable angina or progressive anginal symptoms that may accelerate into myocardial infarction. Also those with multivessel disease or larger burdens of ischemia.
Yes, that was an excellent summary. I personally thought the trial was very well conducted. It was provocative. Like you said, it was the first time a sham-controlled PCI trial was performed. And as you said, the follow-up was only 6 weeks. When I initially read the study, I said to myself, would I actually take these patients to the cath lab at the first place? Because a lot of these patients hit, bruise stage 3 on the exercise treadmill test, as you mentioned as well. What would you say about that?
Well, I agree. There's probably some variation in care. I do think overall there probably are a lot of similar patients that do make it to the cath lab, either because they have typical symptoms and don't have pre-procedural stress testing, or at times we see patients referred in from non-interventional physicians. So I think we have to account for all severities of both clinical symptoms and ischemia extent when we're evaluating people in the lab. And so one approach is to use, invasive hemodynamics to augment our decision making. And as you know, in Orbita, they did perform hemodynamic measurements, but these were not provided to the operators. Like decisions weren't made based on them. And as you know, in retrospect, I believe about 24% of lesions were not ischemia causing that were entered into this trial and potentially randomized to PCI. So I think as with all things we consider, the more information we have about the patient, the better the patient's going to do in the long run.
Sure. Absolutely. Well, thank you for that summary. Moving on to the next study, which you've described in the manuscript. And for the listeners, the paper is available on issue 13.1 of US Cardiology Review. The next paper is Culprit Shock Pci. So essentially percutaneous coronary intervention in patients who present with an acute coronary syndrome and are in cardiogenic shock. And this was looking at patients who were randomized to either the culprit vessel only versus multi-vessel PCI, which was, supposedly what the guidelines recommended and was considered standard of care in patients who presented with an acute coronary syndrome and were in cardiogenic shock. So why don't you talk to us a little bit about that study that Holger Thiele presented?
Sure. Well, the 30-day endpoints were presented in 2017, and more recently, the one-year outcomes were presented in 2018, and that's what we're focusing on. I think it's important, of course, the primary outcome at 30 days favors the culprit only, with decreased rates of death, recurrent infarction, and need for renal replacement therapy. I think having one-year outcomes is really critical, and understanding what happens to these patients that don't get complete revascularization. And the key was from at the end of 1 year, there was still no overall benefit in death or MI to the early multi-vessel revascularization approach. However, out to 1 year, 1 out of 3 patients in the culprit-only group required revascularization. And there was also a significant increase in admissions for heart failure in that group that was incompletely revascularized. So I think the take-home messages from the 1-year results are that once the patient stabilizes from shock, okay, we know the mortality is very high, but in the subset that stabilize, we should pay close attention to, assessing them for more complete revascularization. And whether that be staged PCI or CABG is unclear, but I think just continuing medical therapy alone based on the initial revascularization strategy is really not the way to go. I think one other thing, if we just want to go back to the initial results, I thought the investigators did a great job trying to achieve complete revascularization, but in doing so, they did tackle some very complex chronic coronary disease, including CTO intervention in the setting of cardiogenic shock. And patients did have, state-of-the-art hemodynamic support and ECMO if needed. So I feel like they were cared for in a contemporary manner. But it's unclear whether, there are subsets of patients with multivessel disease that would have achieved benefit without harm, in the acute setting, such as those with, very straightforward, say, type A lesions in proximal vessels. So as a whole, we can say the strategy of, all comers flow revascularization is not beneficial, but still as an operator caring for a lot of these patients, I do wonder if, there are subsets we should continue to study. And certainly if you're unclear about what the culprit vessel is, or you think there's more than one culprit, then there may be exceptions and you should perform multivessel PCI in those settings.
Sure. So, just talking about staging the procedure, would you typically stage it in index hospitalization, or would you stabilize, discharge, and see them as follow-up and then schedule it as an elective procedure? What would be your typical approach here?
In my practice, I do both. Okay. And it really depends on if there's any spontaneous or provoked ischemia during the hospitalization that would warrant a pre-discharge revascularization. Also on the patient's comorbidities, the complexity of the PCI. Typically, if it's a CTO, I would not do that in-house because I do feel like there's a benefit from waiting until the microvasculature recovers, vasospasm recovers. You can have a lot easier time in that type of complex procedure. So a lot of factors are in mind, but I think the key is to do something and not just prescribe medical therapy. That if you're going to consider a delay in revascularization, then certainly doing some sort of risk stratification, or if the patient has ongoing symptoms, that's probably not even necessary. But certainly they should have some form of evaluation post-discharge if they're not completely revascularized. Sure.
So switching gears from PCI and cardiogenic shock to actually unloading the left ventricle, this is the trial that Naveen Kapoor presented, which looked at infarct size and the door to unload time. So why don't you talk to us a little bit about that trial and what you think about mechanical circulatory support and unloading the left ventricle in general prior to attempting to open the culprit vessel. What are your thoughts about that, and what do you think about the study that Naveen presented?
Sure. Mm-hmm. So I think there's animal data to support unloading to reduce infarction size. And certainly that can be done mechanically with a device like Impella, but it also can be done pharmacologically by drugs even as simple as, beta blockade, things that can lower left ventricular end diastolic pressure, treatment of heart failure, treatment of hypertension, can all decrease infarct size. I think this is very, provocative to use a mechanical unloading.
Sure.
And in my mind, this feasibility study does open the door to larger trials. But really, for me, it's a race against time. So it's whether the delay introduced by placing these mechanical unloading device can overcome, can supplant the time delay, whether putting it in and getting the unloading, that benefit can override any benefit of a delay. So as you know in the trial, those that got randomized to the unloading, their door to balloon time was 25 minutes longer. So again, I think 25 minutes in somebody who presents maybe 3 to 6 hours after their MI may not be incrementally a long time, but if somebody is presenting, say, 30 minutes into an MI, then the 25-minute addition ischemia time, may then counterbalance the benefit of unloading. But I think based on the study, I would feel it's ethically sound to pursue a larger trial. And as these devices become more simple to implant, and Impella will ultimately be coming out with a 9 French device. So as the devices get safer and we can implant them more rapidly, I can see in the future that this is certainly an area that should continue to be investigated.
Sure. No, that was an excellent summary, and a very exciting and evolving area in the field for sure. Moving on from medical conditions like cardiogenic shock, to actually lesion subsets. So talk with us a little bit about your approach to bifurcation lesions, particularly the ones involving unprotected distal left main coronary artery bifurcation lesions, wherein what is your approach for stenting? Is it the provisional stenting approach, or is it the double kissing crush approach, the DK crush approach? I know this trial was presented, I believe, at TCT in 2017. So if you can talk to our listeners about that study and how you practice revascularizing this lesion subset.
Okay, so I first wanted to point out there was a recent publication about left main intervention in the United States using the NCDR, and still in the U.S., unprotected left main intervention is still uncommon. It only comprises about 1% of PCI. And there are many hospitals and many operators that perform very few of these procedures. So with that in mind, the DK crush study, I think, is an extremely important study. The optimal way to treat distal left main bifurcation lesions, which I believe is best with the two-stent strategy, because of the compromise of the ostial circumflex, that just based on the studies that have been published so far, my take is that a two-stent strategy should be optimized in these patients. And the DK crush technique seems to be the best way for a few reasons. One, by adding the first kissing balloon prior to the left main LED stent, there's a much better geometric conformation of the ostial circumflex stent. And second, it is much easier to recross and do the final kissing balloon, because if you are unable to do the final kissing balloon after a standard, mini crush that is done as a single deployment, or as staged without the kissing balloon in between, then certainly the outcomes in the side branch are going to be far inferior. And I think it does take a little bit of practice to get this strategy down because the number of steps involved. But when you achieve them, the outcomes are certainly better. And in addition to doing the steps and the strategy, intracoronary imaging should be used in every one of these patients to assess the outcome in both the LED and the circumflex, as well as the proximal left main. So I think those operators that want to undertake this lesion subset really need to be facile with multiple bifurcation techniques, but the DK crush performance of that is certainly, I think, a must. And the operators in this trial, keep in mind, they were all extremely high volume operators, over 300 PCIs a year, and also a very high volume of left main intervention. And just putting that in context of the opportunity that most U.S. operators have, I think for those individuals that are really not comfortable with this lesion subset, then they could certainly be referred to a center where treatment of left mains is more common.
Terrific. That was a terrific summary. Thank you for explaining that so well for our listeners. The next trial that I want you to discuss is the trial that Manos published in Lancet, and that was, for that of Saphenous graft vein interventions with a bare metal stent versus a drug-eluting stent, the DIVA trial.
Sure. I'm still amazed that we know so little about saphenous vein graft degeneration and reasons for PCI failure, and this DIVA trial, I think, points that out. You'll probably recall the controversy that went on in the era of first generation drug-eluting stents.
Sure.
When we saw pretty poor outcomes with both sirolimus and paclitaxel stents, and there was some concern that drug-eluting stents were harmful in vein graft. So now, fast forward 10 years later, And we're not seeing any harm, but we're not seeing any clear benefit of using drug-eluting stents in this particular lesion subset. We know that event rates are extremely high, that some of the repeat revascularizations, many of the TVRs may not be TLRs, but I think it's the one lesion subset where I almost think we need to go backwards and do some basic, pathophysiology studies, like serial imaging studies, to find out the mechanism of why failure is occurring so that we can design better trials.
Sure.
I think, DIVA trial is, more one-year outcomes, but we also have ICAR CABG 5-year outcomes, which paradoxically showed lower TVR with drug-eluting stents early, but then twofold higher TVR late. So again, either this is, we're not having neointimal suppression because maybe the drug dosing is not sufficient in veins, maybe capillary leak is worse in veins, promoting very early neoatherosclerosis. It could be a number of things, but I think something like a serial OCT study would be quite helpful to understand that. And I'm certainly interested in trials that are going to look at whether we should, approach native vessels more often for vein graft failure. When in the lifetime of a vein should it be sacrificed for the native vessel? And maybe with the future, avoiding vein grafts altogether with more arterial conduits for surgical revac. Those are all thoughts I have, but it's a very interesting lesion subset.
Sure. So, do you, in your practice, then, if a vein graft is down, end up revascularizing the native vessel, or do you still go after the vein graft? What's your strategy?
Yeah, I think for chronic vein graft occlusion, certainly the native is always my approach. In the setting of STEMI, when the vein is thrombosed but acutely, if there is a native option and a non-CTO option, then often I would prefer that. The decision's a little more difficult when you have degeneration that can be treated with a single stent, particularly if it's applying a native vessel that's complex to treat. But certainly in some circumstances with recurrent vein graft failure, I've looked to revascularize the native. The things that makes me a bit concerned would be, it's unclear if you revascularize the native, what you should do with the vein graft. Do you leave it open? Do you close it with a coil? Do you wait for it to thrombose on its own, in which case it could still embolize the native vessel? So there's still, in my mind, a lot of questions about the strategy of the native vessel, depending on the patency and disease state of the vein. So time will tell, I guess, when the trials are performed, what happens to the natural history of those veins that are not intervened on.
Sure. Perfect. Terrific. So moving on from lesion subsets to actually physiological assessment of lesions. And I'd like for you to discuss the preferred method in your practice when you want to assess the hemodynamic or the physiological significance of an indeterminate lesion angiographically. Which method do you utilize? Is it the instantaneous wave-free ratio, or is it the fractional flow reserve? Because clearly the advantage with utilizing instantaneous wave-free ratio, and is something which I've incorporated into my practice, recently, like 4 to 6 months ago, is that you get an instantaneous number and you don't have to worry about administering adenosine in the cath lab, or mixing adenosine, or starting an intravenous infusion like it was performed in the FAME trials. So talk to us briefly about those methods for assessing physiological significance.
Sure. Well, I would say I think over the past few years, we've certainly had an uptake of use overall of either IFR or FFR both for culprit and non-culprit stenoses and for making decisions in multi-vessel disease, which I think is supported by, the registry studies, one of which, the Define Real, was discussed in our summary paper. But, since Define Flare and IFR Sweetheart were published, I'm very comfortable using IFR with a dichotomous cutoff of 0.89.
Sure.
There are some operators who still like a hybrid algorithm using hyperemia with cases that are close to the cutoff. But I'm pretty confident that, particularly among patients with stable angina, you're really talking about, if there's subtle differences in the threshold for PCI. I mean, IFR in general will result in lower rates of PCI than FFR based on those two studies, the randomized trial. But if, the comfort level is there, in my mind, you don't lose anything by deferring the PCI by IFR. If the patient remains symptomatic, certainly you could always readdress it. We certainly are using IFR for the acute MI, so you don't have to give hyperemia for any patients with, contraindications to hyperemia. We still do both in the sense that we want to keep facile with both techniques, and I think it does take some experience really monitoring closely for wire drift and really checking your measurements, normalizing pre-lesion, checking, doing pullback is often important to really understand where, if it's lesion specific or vessel specific, meaning sometimes there's serial lesions. So there's a lot of subtleties to interpreting these results that you learn more and more about as you do these techniques more often. I'm really looking forward to some integrating angiographic and hemodynamic systems. I know Philips is coming out with a system where you can put down your IFR wire, do a pullback, and then have an overlay with the angiogram of exactly where along the course of the artery you have decrements in your IFR. So I think a hybrid anatomic physiologic algorithm will help us understand where we should stent, which lesions we should stent. But until that time, I think we have to really use the information wisely and also check our post PCI, IFR, and FFR. As you know, the recent registry showed that a lot of times at the end of our intervention, we are still leaving the vessel with ischemia.
Yeah. Perfect. Well, this has been sort of like a rapid fire round of questions for you, and you've been exceptionally terrific. I'm going to end the interview by asking you to discuss two stent technologies. And, for the listeners, just if you could differentiate what is bioresorbable or bioabsorbable vascular scaffold versus a bioresorbable polymer. Because these are two different technologies within the stent technologies, and we clearly,
sure.
We clearly have trials for both of these. So if you can go over that to end our podcast, that'll be terrific.
Sure. The desire to make iterations of our second generation drug-eluting stent is probably now about a decade old, and really started in the era of first generation stents, where we were seeing a lot of late stent thrombosis. I just want to remark that it's amazing that the 5-year outcomes of the current generation drug-eluting stents show stent thrombosis rates that are well below 2%, actually in the 1.3 to 1.5% range.
Absolutely.
So that's our benchmark. Okay, so with that benchmark in mind, there's still a thought that even with the very biocompatible polymers, if a stent can be polymer-free over time, that is, if the polymer can bioabsorb and break down into CO2 and water, that if you're left with a bare metal scaffold, there could be some advantages to the patient in terms of endothelialization. Maybe not in long-term endothelial coverage, but maybe in endothelial function per se.
Sure.
Although some OCT studies have shown maybe earlier endothelial coverage, I think when we're talking about late events, it might have to do with the endothelial integrity. So I'm still on the lookout for a signal that these stents with the bioresorbable or absorbable polymers could show superiority in certain very high-risk subsets, but that's yet to be seen. I would say the data so far supports non-inferiority. As you know, in the US, we have Synergy approved. There will be more to come. I think when using these devices, you have to be cognizant of the time period over which both the polymer and drugs absorb or are eluted, because there may be differences in efficacy in these devices if the elution is too quick or the absorption is too quick. And Pioneer 3, which is the Buma stent, which is a sirolimus bioresorbable polymer stent, which is currently in phase 3 trial. The phase 2 trial showed it failed to reach non-inferiority for late loss. The late loss was nearly double in that stent. And again, so I don't think we can make class generalizations, first of all, with all of these novel devices, which is going to make it a little more difficult to prove their benefit compared to our current generation stents. But I still believe we will see some new combinations coming out that will be very interesting. And then with respect to bioabsorbable vascular scaffolds, I'm among individuals who believe it is really a need in our field. And, of course, now that the durable metal alloy stents are so thin, a lot of people feel like, we're not going to do better. And there's a lot of risk involved in developing new products, a lot of financial risk, and patients have to participate, and it will take years to know whether these devices are going to be non-inferior or potentially superior. But I do see, young people, we see people coming back to the lab year after year, decade after decade, at times with, numerous durable metal alloy stents, sometimes in multiple layers, multiple configurations. And I do think we'll need to progress to a fully absorbable stent. And there are a few now in trials that are approaching right under the 100 micron in thinness. And I know Abbott's going to be testing theirs in peripheral artery disease. And in addition to the PLLA ones, which have been the most widely studied, there are some new iron-based scaffolds that would be broken down into hemosiderin. These can be very thin, like 70 microns. So we're going to see some novel composition of bioresorbable scaffolds, and I'm really excited about the next 5 to 10 years in that area.
Yeah, no, excellent summary. Perfect. Thank you for taking on that question. I know it's been a controversial area in the field, and you've explained it beautifully. Well, there we go. Thanks a lot, Dr. Abbott, for your time and for answering all these questions, going over the vast majority of the paper, actually, which is a very well-written paper. I urge our listeners to actually read this paper because it provides an excellent summary of all the developments that have occurred in the past 1 year. Thanks once again, Dr. Abbott, for being with us.
Okay, and thank you, and thanks for the opportunity to speak to you today.
Yeah, it's my pleasure.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.